Good evening, everyone. We are very slightly past 6 o'clock, but we have a very packed agenda. So I thought we should make a start. For those who are watching on the live stream, I'm Councillor Josh Blacker, Chair of the Health and Wellbeing Board. And although I can see name tags, if you could introduce yourselves the first time you speak, for those who are watching along at home, either now or at their leisure later, that would be wonderful. I've had a couple of apologies from Councillors Nagpal and Mahfouz, and I think others as well, for various reasons. They apologise that they can't make it. Are there any declarations of interest? One day there will be, so we do it anyway. Number 4, there are no matters to be considered in private. Was everyone happy with the minutes of the previous meeting? Yes. Fantastic. I shall sign those as appropriate, which brings us on to Carleen and the Health Watch update, please.
Good evening, everyone. I'm Carleen Duffy. I'm the Health Watch Area Manager. So I'll take the paper as read, but I will quickly summarize it. So in Q1, we spoke to 1,294 people between April and June. The GP services received the most positive feedback for staff attitudes, with 88% satisfaction, particularly praising doctors and nurses for their professionalism and kindness. The quality of treatment was well received at 89%. Negative feedback highlighted concerns around appointment availability, long waits for phone bookings from 20 minutes to up to an hour, and extended periods at health premises, and a desire for more face-to-face appointments. Hospital services had 86% positive for staff attitudes, 88% positive for treatment quality, and 90% positive for service management. The patients appreciated the friendly and culturally sensitive staff, as well as effective treatments. I shall move on to our current enter and view program. So at the moment, we are looking at nursing homes. We have completed 4 enter and views in nursing homes that have been rated good by the CQC, and we're currently visiting 4 that require improvement. The overall aim is to draw out good practice and highlight any areas of improvements. So far, we've made 31 recommendations in the good nursing homes. We have also included our information and signposting, this continued experience program. The last quarter, we've handed out 31 leaflets around childhood and winter vaccination, 41 around mother and baby groups, 108 around We Are Primary Care, 53 of the Wellbeing Recovery College prospectuses have been handed out. While difficult to assess the impact of this, services tend to notice a small jump in inquiries, or we receive more information in signposted inquiries about these services in Ealing. We are currently doing 2 research projects, one in the maternity experience of asylum seekers. This is subject-led. We have allowed the participants to inform the study and the recommendations. We went and spoke to asylum seekers and asked how they would like us to engage with them. They have chosen 2 forums. We have hosted one of these where we did 13 in-depth interviews with 13 asylum seekers and further group discussions. We have another one booked for December, and this will include the doulas. We're also doing a snapshot in the hospitals of maternity services in general, as a comparison. Our second project is in community vaccinations in younger people aged 0 to 25. The same survey is going to be given to school children, as we're currently using and piloting in GP surgeries. This is to examine the young people's attitudes toward vaccines, including a snapshot of the general population of Ealing residents' attitudes toward vaccinations. This will be done through a multifaceted approach, surveys, discussions, and activities in schools. The goal is to see if we can foster a healthy understanding of what vaccines are, how they can help individuals in their communities, and if there are any barriers, in particular to those that face additional language or cultural barriers. And that is the end of the Health Watch update.
Thank you. Do you want to come in on the vaccines? Because I think public health have done a lot of work in that area, which might be very helpful before we then go to general questions. Because I think there's a
Thank you, and thanks, Colleen. No, I was just going to say thanks for linking up really proactively with the team. Raj is here as our public health principal, and it's one of her roles. I don't know, Raj, if you want to say anything.
Yeah, I think,
Pesky little person. There you go.
so I think Carleen and I, we're due to meet, I think, in a couple, probably next week, I think it is. Yes. So we'll catch up, both of us, about that and how we can work together on that project, because I think it would be good to get those views actually from the community, because uptake, if we want to increase uptake, then I think those views are really important. Thank you.
brilliant. Thank you very much. So the link is already made, so it's really good. But I think shows the value of having everyone around the table and these relationships. Any other questions for Carleen from members? Kerry.
Thank you. And it's just a reminder in terms of the importance of the Enter and Review programme that Health Watch have been carrying out in partnership with the council and other partners with regard to driving up and improving quality within the care home sector in the borough. And it's been an effective and a supportive way of supporting providers improve the quality of their care offer.
Thanks. Anything from anyone else? No, I think very good to see the kind of Q2 and Q3 and Q4 all empty, which is understandable given it's the first quarter, but very helpful to see that we're planning to get that kind of longitude, well, almost longitudinal in it. And if you can do a longitudinal in a year, that view across the year will be really helpful. So I think we'll probably have more to say when we see those numbers going up or down through the quarters. But if there are no further questions from anyone, thank you, Carleen, again. And just echo what Kerry said about the H&WBB programme. It's a really important part of helping us drive up quality in the sector. So thank you very much for that. I think Rajwinder is going to take us through the adults mental health JSNA.
Yeah, so there's 40 plus slides, I think, in the pack. So what we've done is we've got a short update for everybody and I'll whiz through it because I think some people have seen it already maybe around the room. So I'll do a kind of whistle stop tour of it. So it's the it's the mental health one. There you go. Thank you. So these are really the key findings from the mental health JSNA chapter. And like I said, it's taken us, I think, nearly 9 months to pull this together. And we've done a lot of quantitative analysis and a lot of qualitative analysis as part of the process. So we've gone out to the community, we've gone out to professionals as well. So it's just capturing all that information into a few slides for everybody. So if we go to the first slide, the first slide shows the PCNs across Ealing and their prevalences across depression, severe mental illness, talking therapies, community mental health referrals, and long-term mental health inpatient admissions. I'm not going to talk through the data. I'll just sort of presume that people have read through the document. If there's any specific questions, I can pick them up at the end. The next slide goes further into that information, and it looks at the variation in depression prevalence across PCNs in Ealing. And I think across all the groups that we presented I've presented this information at, it's always, one might expect the Southall ones to be higher up in that depression prevalence because of deprivation, but obviously it's lower. So we've had lots of different discussions, I think, with our clinical colleagues, our community-based colleagues, and the Mental Health and Suicide Prevention Board around why is that? Is it read codes? Is it something around cultural stigma and not talking about problems and all these sort of things? So I think it's led to a lot of discussion going through, the slides. So the next slide, again, looks at kind of our population ratio and the referrals to adult talking therapies, and then the appointments that are attended. So these are our community-based services for people with common mental health problems and the access. And again, it's the same, if you look at the PCN map, you can see there's lower uptake and attendance from those from North and South Southall. So it's just I think this is like the start of the journey, I would say, rather than the end. I think it gives us that kind of what do we want to do next type thinking around it. So the next slide is then we just sort of pulled together some recommendations. So we've divided the JSNA up into common mental health problems, and then you'll see the next sections along. And this is obviously coming, the recommendations come out of the, you know, the information that we've gathered, you know, and they're around looking at read coding, looking at stigma, looking at, you know, how do we work more as a collective across Ealing to tackle some of those issues. Like I said, I'm going to do a whistle stop tour. So if there's specific questions, do stop me. And the next slide then is we focused on long-term mental health conditions, and that's all our sort of more sort of crisis services as well. And, you know, we looked at our adults ratio by ethnic group and, you know, our community mental health referrals by PCN, you know, across Ealing. And if we go to the next slide, please, Sam. One of the things that I think we found we kind of came out of this piece of work that's really, really key is this kind of overrepresentation of Black British population between the 18 to 25-year-old age group in inpatient services. And that's not just males, it's females as well. So I think a lot's come out of doing the JSNA chapter, and I think there's a lot for us to think about going forward in terms of, okay, so what's our universal messaging? What's the targeted offers that we need to think or invest more in? So that was another, I think, key thing to think about going forwards as well. And again, if you look at the PCNs, again, you know, if we thought about deprivation and all those things, does it kind of match across the two? So, Sam, if we don't, thank you.
Sorry.
It's all right. And then we looked at kind of mental health sections and those people that are sectioned, and you know, the police provided that wonderful little graph, the line one, and they showed how they'd seen such a marked increase in the number of people that they were supporting through section 136. But obviously they've got a new strategy around some of that now, and it's thinking about actually what's going to happen to those people that were being supported now that we don't have that support through the police. So I think we need to think about some of those things going forwards as well. So taking us on to the next one. So this, we done a coroner's audit of our completed suicide files from January 2019 to March 2022. The report is a lot larger than this, but we've just picked up some of the key data really for people to see. And as you can see, I think one of the things that we find the most difficult is, you know, ethnicity and all these things are not readily recorded, or you can't find that information when you go through the coroner's files. And so we were able to find place of birth. And when we look at place of birth of our completed suicides, there were 52, the 17% of them are, their place of birth is Poland, and 17% of them, their place of birth is London. So in terms of our figures locally and having that local intelligence, that local knowledge, it's really important for us to think about how do we target our suicide prevention work, and how do we think about self-harm locally as well. So, you know, this information, like I said, it's just the sort of key findings from all of that. And if you look at the graph underneath, the kind of chart one on the right or left, depends sometimes how you're looking, isn't it? But the one at the bottom, that looks at kind of contact with GPs and any contact with primary care. So I think, again, this is another piece of work which is the starting point for us, and, you know, moving that along and thinking about actually what are the tangible actions we can do with the resources that we have. So thank you, Sam. And again, the recommendations kind of reflect what I've already said. You know, what is it that we need to do locally within the capacity and the resources that we have? How do we take a kind of proportionate universalism approach to that, you know, in terms of thinking about what's universal and what's a targeted offer? Thank you. And then we looked at risk factors as well. And, you know, we know there's lots of evidence, there's lots of research around, you know, people that have serious mental illnesses, they also have poor health improvement type behaviours. So that sort of covers some of that. They also have comorbidities and serious mental illnesses as well. So it's important to sort of think about actually if somebody is got bad healthy lifestyle behaviours, that's going to impact on their, you know, on their long-term condition anyway. So it's kind of looking at those links as well. So and then we had some recommendations that reflect that within the slide set. We're nearly there. So we actually did a number of, I actually did a number of focus groups and one-to-one interviews with professionals and service users across Ealing Borough. And this is some of the information from the thematic analysis that's come around that. And believe me, I had lots of flip chart paper with pens in my house for a very long time while I was doing the thematic analysis of that. And Vaish, who's our consultant in public health, she kindly, we both did it together actually. And you can see the things around inequality, cultural competence, the stigma a lot of these communities have around mental health, and I mean, I can give you one of the examples that was given at one of the focus groups was when the person asked a group of Somali focus group was, okay, so how many words have you got for the word goat in our community? And they're like, oh, more than 100. And then she goes, well, how many words have we got for the word mental health? And they were like, there's only one, and it refers to crazy. So I think that kind of insight and that information, bringing that back from the communities, understanding that actually there isn't a language maybe from thinking about mental health in some communities as well. And accessibility, we need to think more about the wider determinants as well. When we think about mental health, poor housing, deprivation, coming from a place of trauma, from refugee asylum. So I think all those things, we need to incorporate all of that into our services. And it's a lot to think about, I think, really. Yeah, nearly there. And so that's the other, and I think these ones are specifically from the focus groups that I did with the community. And that's it. Thank you.
Thank you very much. And I mean, even the shorter version suggests there's a lot of work in there, and the longer version, I think, that we have circulated shows just how much work has gone into it. So thank you very much for that. Anna.
Thank you. I think a big thank you to Raj and a lot of colleagues for working on this. I think when you talk about adults' mental health, it's so massive. There's so many different factors, especially when you start looking at comorbidities and risk factors. I think one thing I was just really, I suppose it's depressing, but also pleased to see is it's really reinforcing all of our things in health and wellbeing strategy. It's just with a mental health focus, and I'm hoping that an awful lot of the more general actions that we're taking forward through the strategy will help with this, and vice versa, that this work and the strategy that's going to come out of it and the suicide prevention work will really feed into the ongoing action plan for the health and wellbeing strategy. So I think we just need to be really careful not to see a mental health strategy as something over there that's totally separate. It really needs to be woven into everything we're doing. Thank you.
Which probably answers my questions about next steps and monitoring recommendations going forward. But there we go. Neha.
Yeah, I just had a message from Chris Hilton, who obviously is part of West London NHS Trust, who run our mental health services. He is going to try and dial in, but he's running late. Apologies from him, that's all.
Thanks for passing that on. Kerry.
Thank you. So a number of, one question and a couple of reflections, if that's okay. I was meeting with colleagues from the Mental Health Trust recently, and they were talking about the overrepresentation of people with mental health needs in Acton, and whether there's an issue there in terms of the access to IAPT, and whether there's a targeted resource that we need to be considering for Acton. And when they refer to Acton, it will be a different shape and population from how you're necessarily describing in the report, Raj, but I think that's something that'd be of use. I think in terms of the reflections, I think the overrepresentation of Black men and women under Section 3 of the Mental Health Act is something that has been around for a very long time, and I don't think any health and social care system has really been able to impact on this at this stage. And I think for us to take national learning and have clear plans is very much in line with our wider health inequalities issue, because the knock-on health impacts of that significant overrepresentation is something we as a health and wellbeing board and as a system should be taken into account. And I also think the excellent work that Raj and the team have been doing in terms of the engagement around suicide prevention and the overrepresentation of Polish men within completed suicides is again an inequalities issue, and in terms of how we as a system respond to the needs of people within that community.
Thanks, Kerry. Who wanted to pick up the question at the beginning? Or was it just a rhetorical one?
I think it's about how we work to engage with Acton and understand what the specific issues are within that area and act upon that.
Neha.
Thank you. I can tell you some of the work that we've already been doing around this arena, and Chris, I see, has joined as well, so I'm sure he'll have more to add. But we've been looking at this data for some time. So when we say Acton, the community mental health team is split into 3 teams across the borough. There's a Southall team, there's a north part of the borough, and then they call it Acton, but it's sort of the east part of the borough, includes Central Ealing and stuff like that. So, and when you look at the referral rates into the different teams, the numbers of referrals for the population are much higher in the east part of the borough than some of the other parts in the borough. It goes back to what Raj was talking about in Southall. So the workforce is sort of distributed based on what we think the predicted prevalence is, but the demand in Acton is so much higher than Southall that it starts to create a bit of a difference in the waiting list. So the trust has been doing some amazing work with the teams as well to try and look at what they can do to help improve those waiting lists, but then also not destabilize the Southall team, because if we can crack some of the stuff that Raj, you were talking about around some of that stigma and that, then possibly the demand in Southall might go up. So you don't want, it's a fine, delicate balance that the teams are actually working through. But I know this is a very live conversation that we have in every single mental health meeting that we have with the trust.
Thanks. Chris, I don't know if you have followed along, and not sure quite when you joined. I don't know if you've got any reflections or whether you might be able to also update us on the Northwest London strategy for mental health and how that might help.
Apologies, Chair, for being late. And I can check that I'm audible before I start talking.
Yes.
Okay. So just to pick up the point that Neha was just making regarding to the disparity between the different primary care network teams within Ealing. In fact, this afternoon, I've spent the afternoon with our MINT consultants from across the 3 boroughs that West London supports to try and understand how we can better manage the different ways of working across the teams to meet the demand that we're experiencing, which has been higher than was originally forecast. We're looking particularly in Acton at the work that we can do with primary care referrers in order to understand why there are different patterns of referral into the Acton service than we would have predicted based on the demography of that primary care network. So that work continues, but what I'm very keen not to do is redistribute money within the borough in a way that disadvantages areas where we understand the population is underserved. So that is work that continues, and we're working really closely with, particularly with primary care, in order to do that. I think your second question was about how the Northwest London mental health strategy is developing, and it has been developing at pace. There was a presentation at the Mental Health and Learning Disabilities Exec team last week around some of the emerging findings from the data that's being captured at the
Chris, you've broken up slightly.
Patterns of service that have. Tell me if you'd like me to stop, Chair. Otherwise, I'll attempt to carry on.
I think you're back. So try again, and I'll let you know if we can't hear you.
Apologies, this is obviously not ideal. The Northwest London strategy continues to be developed. They've done a lot of work crunching the numbers, and especially looking at the differential investment into mental health services historically between the inner and the outer boroughs. And we're now trying to use that to inform how future investment will be directed. And certainly from a West London Trust perspective, we've got particular interest in that work because it favours greater investment, particularly in Hounslow and Ealing. And we'll be working hard to demonstrate that that money's heading in this direction.
Great, thank you, Chris. That's promising for now, but we won't hold you to that promise yet, given the strategy is not yet published and finalised. Any other comments or questions? I've got VJ and then Robert.
Yeah, just from my perspective, being a GP in Acton, and certainly in Acton historically, we've always seen a significant level of mental health. And the reasons why there is this disparity is partly due to the level of awareness in Acton, which is much more significant compared to, for example, in Southall. But it's also in terms of the level of understanding within primary care as well, and their ability to support these individuals, but also having that higher level of understanding and awareness around the services on offer in the community to provide that mental health needs support. And so that's part of the reason why the number of referrals to the community mental health services is higher in Acton versus in Southall, where I believe a lot of it's around the stigmatism around what does it actually mean for the community if you label someone as having a mental health illness, and how that then impacts on their ability to integrate with the rest of the community in that area. However, that does mean that there is a level of unmet need in areas like Southall and Norfolk. And as Chris and as Neha has said, we continue to work with the community mental health services as well as the community to really raise the profile and awareness about mental health and try and destigmatize it. And so because there is a lot of services, voluntary as well as through health services, to support these individuals. And so, it is important that we absolutely raise that profile. And then the other community of ethnic group, which you did mention, is our BAME community. And we do know that there's a disparity in particular in terms of Black and Afro-Caribbean in relation to mental health, particularly when in terms of mental health crisis and the increased incidence of those being admitted to acute psychiatric wards compared to other ethnic populations. And that's partly related to the fact that partly that relates to them not reaching out when they potentially feeling unwell, or not having the insight or realization of what's out there to support them until they get to a crisis point when they're then admitted to acute psychiatric unit.
Thanks, VJ. Robert.
Thank you. Thank you very much for sharing the reports and the information. I thought the insights were incredibly helpful. I'm quite interested in terms of pathways for children and young people, and thinking about suicide prevention, almost working backwards from that point. We have some incredible interventions that take place within schools that have a huge benefit for our school population. But I don't know if you've, rather than a very specific question, but do you have any thoughts in terms of how we might think about suicide prevention from that earlier stage, and almost just work backwards and think about what we might develop and within schools, or just generally messages that we undertake as part of our business as usual work?
So it's quite interesting you say that, actually, because earlier this morning I was going through the thematic analysis of all our workshops that we've had and looking at our actions and our action plans for suicide prevention and self-harm locally. And schools, by all means, is, you know, if we're thinking about giving every child the best start and all these sort of things, then schools is definitely the best place to start. So we do actually have some actions around working with schools in that. And I think that what we've tried to do with that is make our actions tangible, so that they're things that we can actually do, rather than have this kind of high level suicide prevention and self-harm action plan that actually sits in a cupboard and doesn't always get a lot done with it. So we've really made it kind of thinking about actually what can we do in schools, you know, Papyrus, there's lots of really good organizations out there, Ripple, there's that we could work with and try and embed, because I would rather see a sustainable thing rather than getting someone in to come and deliver some training. I think we need more than that. So I think, you know, with our schools colleagues and our children and young people colleagues, I think I did reach out to some of the colleagues in our children's services, and unfortunately they weren't able to make the last workshop, but we will be, you know, schools is definitely really important for us in that work.
Just very quick, I'd really welcome that contact, and I'm sure my colleague here, Julie Lewis, both of us would be very interested, because we've been undertaking a series of visits across a number of our schools, and actually we do see those incidents and the impact that obviously it's terrible impacts on individual families and school communities as well. So we would be really keen to work with you in terms of developing our response, which I think we have a really positive response, but there's much more that we can do.
Yeah, and I think there's some good practice from other areas that we could probably pick up around that, I think, because and this might just be my perception, but I think we can definitely join up more around this and think about actually, if in the event of self-harm or all these things, what can we collectively do to support a school in tackling some of these issues? And perhaps, you know, we need to do some of that thinking before we approach the schools.
Thanks. And Anna.
Thank you. And just to add to that point, thank you. Every year we do our annual public health report, and we're working with Raj and Vice using this information to focus it. I think especially coming out of COVID, I think mental health just and the inequalities aspects of it is really key. So we're trying to do it focused quite short, but on the inequalities aspects, but also on the prevention side, and very much talking about that kind of life course, because all the inequalities and everything you see in there is it's not, you know, starts in adulthood. There's so much evidence around importance of families, parenting, all of that. So absolutely in there is a bit of a kind of advocacy piece as well.
Great, thank you. And Councillor Anand, sorry, I was just noticed their hands online. So Councillor Anand first, and then we'll come back to you, Colleen.
Thank you, Chair, and apologies for joining late into the meeting. Thank you for all that information that's just come through. And I absolutely agree, there's a huge stigma, there's a huge gap in the BAME community with regards to mental health issues, whether they're at low level or whether they are actually at a sort of a higher level. I think we might want to be out there raising awareness and working with a lot of the religious organizations or faith groups and having some champions in these organizations who could support the services which are sort of out in the community for families to access. And it's making sure that this champion in these organizations would have that understanding of how they can be able to sort of not promote, but be able to support those vulnerable families in understanding that these services are available and they can work with the services to, you know, be able to help those young people or older people that do suffer from mental health. It is a huge gap in the community, and for years we've been struggling to make sure that we've got those awareness in the community and they know how to access these services. But some of these organizations are voluntary sector organizations, you know, religious organizations. Maybe we want to work with them and having champions in these each areas to support the vulnerable community and the BAME community at large. Thank you, Chair.
Thanks. Anna, I don't know if you want to talk about the Champions program and how that would fit in on that.
Yeah, thank you. And thanks, Councillor. And I think we've talked before about kind of links with faith and voluntary sector organisations. I think there's a lot of that in terms of the kind of infrastructures through health and wellbeing strategy as well. I know recently kind of resetting up kind of some of the interfaith forums, some of those structures that we started in COVID, which I think really helpful in there. I think we are, there will be work in there, and I think we can look at the recommendations specifically through, especially the suicide action plan and the mental health strategy. I think also with our community champions programme, we've had quite a strong steer from us, but also a very strong request from our champions around mental health. So we've had at least one session. We are exploring as one of our actions mental health first aid training, and through our champions programme, and also the suicide prevention. There's a kind of 40 minutes realistically online suicide prevention training, which is through videos, lived experiences, really powerful, really simple, and that's something we're sharing quite widely as well.
Great, thank you. Carleen and then Chris again.
Yeah, I was just going to say around the young people in schools and things. That was one of the first projects I did was around the response to COVID and the effect that COVID had on mental health in young people. And one of the things we found, there was a positive aspect that young people felt that they felt more mature and more connected to their family through COVID. But yeah, there was a lot of stuff around needing help and more support in schools. And we developed a whole set of recommendations around schools, which we took up to the NIHR. So I'd be quite happy to sit and talk through some of the recommendations that we came up around young people.
Great, thank you. And Chris.
Thanks. If I'm still audible, I just wanted to make two comments. One was around how we're trying to support through the services commissioned through the NHS in Ealing, greater accessibility for communities that we've historically not reached. And I think this is consistent with the health and wellbeing strategy and the trust strategy. And that particularly relates to moving more of our services to be self-referral, and that includes our talking therapy services, which will shortly be rebranded and relaunched in the new year. And they're available in a range of different languages and modalities to support different communities. In addition, the work that we do through the Recovery and Wellbeing College, which individuals, anyone living in Ealing can refer themselves to, and its relocation to Brentford Football Club to be in a much less clinical setting. And I also thought it might be helpful to pick up the point that Robert made about the upstream work that we can do with children and young people. So there is a programme of work looking at transitions for young people from 16 to 25. And we're in a relatively positive place in Ealing in terms of mental health expertise in our schools through the Trailblazer programme and some of the other tier 2 mental health support offer. We're really working closely with CLTH in their school nursing programme. And I just wanted to highlight, of course, some of the self-referral offer for children and young people includes the Circle, which was built in South Ealing as a walk-in facility for individuals in mental health crisis. And then finally, one other evidence-based intervention which we've commissioned in Ealing, which I think applies for individuals who've experienced suicide, is the suicide post-vention service to support the survivors or the surviving families of individuals who died by suicide. And I'm happy to share the details of that with members of the board.
Thanks, Chris. It'd be really helpful if you could, and thanks for the update on the services. So I don't think there are any other comments. I think we can note the JSNA and thank Rajwinder and colleagues for all the hard work that's gone into it. So thank you very much. And I think, Neha, we're moving on to the not the medical examiner's review of coroner deaths, but an update on I think we've still got a slightly wrong title on the agenda, but it's medical examiners' work in the community.
Yeah, it's actually
Oh, sorry,
BJ Taylor and Dr. Sarah Cox and Peter Hare have joined online as well.
Yeah, so first of all, I just want to introduce myself. I didn't get a chance earlier on. BJ Taylor, I'm a GP and Borough Medical Director for Eden. And on the call, we've got Dr. Sarah Cox, a lead medical examiner and a consultant in palliative care at Chelsea and Westminster, and Peter Hare, who works with the medical examiner's office in London Northwest on the call, who are here to support the conversations as well. So in terms of where we are in regards to the medical examiner services in the community, first of all, just from a national context perspective, for a few years now, within Acute Hospital Trust, the medical examiner's office has been established and implemented, where each death in an acute hospital setting, there was a review and support in terms of the death certification in those acute settings. And within the white paper in February 2021, there was a provision in there to include that the services of medical examiners, particularly in relation to death certification, would become statute, and hence the government decided, and in fact it has been delayed by 1 year. In fact, it was going to be April 2023. The decision has been made that all deaths that occur in the acute setting as well as in the community, which are non-coronal, will now need to go through the medical examiner's process as part of a statutory requirement. The role of the medical examiner is primarily twofold. One is to support the individual clinician doctor who's completing the medical certificate, particularly in relation to the cause of death and also the accuracy of completing the death certification, but also to support the family in terms of reaching out and engaging with the next of kin and family in relation to the loved one's death, particularly with respect to if they had any questions or any concerns around the death of their relative or a loved one, and really to provide a supportive approach in terms of any lessons learned, either positive lessons learned regarding that process, or whether there are any themes that can be used to help support clinicians and doctors and the services in the community, as well as Acute Trust, in terms of the experiences around death itself. And so this process has now been established in the community in what we would call a shadow form. Over the last 2 years, key stakeholders and individuals across Northwest London have developed a task and finish group, and we have been working collaboratively to work through how we will be able to implement this in the community, so that we are ready and prepared for April 2024. This whole entire process needs to have a timely turnaround from the time when the death occurs, for the individual doctor to notify the medical examiner, for them to then do a review of the clinical notes, have a level of engagement with the family and the clinician to then agree that the certification can take place, and hence then the registration of that death with the local registrar's office. And so this process needs to happen as seamlessly as possible, and hence we have been working in Northwest London to work out a seamless way of that information exchange from the GP records to the medical examiners. And what we've developed and established in Northwest London is to use community modules for EMIS and System 1 at each of our medical examiner offices across Northwest London. And these are all based in our 5 acute trusts. And as on the slide, it shows where for Ealing, our local medical examiner office is based at London Northwest Hospital Trust at Norfolk Park. And you can see on the slide where the other medical examiner offices are also based. And so their ability to have real-time visibility to the medical records, so that they are able to then review those medical records in terms of the the period of care that individuals had, so and also to support the doctor in terms of the completion and accuracy of the medical certificate. And so what is going to be really important is the timing of this, particularly for faith deaths, in relation to specific requirements around trying to complete this process within a 24-hour period, when there are requirements regarding faith burials, particularly in relation to get those certificates completed so that the death can be registered at the local authority offices. We have produced some really good resources on our website, not just for the health professionals, but also for the public, in terms of what this actually means. And there are some useful FAQs and a video, which Sarah Cox kindly agreed to be filmed, which actually goes through that process and with a great deal of clarity, so that particularly for the public, they have a really good understanding of what is the role of the medical examiner, and the whole purpose of why we want to try to do this. And this is really on the backdrop of some of those high profile cases that we've had in previous years, where there's been perhaps deficiencies in what has happened in terms of the history as to why an individual passed away. I'm just going to hand over to Sarah or Peter if they wanted to just add anything further to what I've just described.
Peter, shall I chip in first? Is that all right? So thank you so much for inviting us to attend and to present, to share the presentation of the medical examiner service. I think across North West London we can be really proud of the way this has been developed. It's been a really collaborative effort. It's been an enormous piece of work over the last couple of years, but what we're left with, I think, is superior to in many other sectors. And obviously Ealing is benefiting from that. I think that there is a third strand apart from the accuracy of the justification and supporting relatives, which is learning, which is just the previous slide to this one. And this is really important. I think this is the opportunity to improve the care that we deliver through learning from scrutiny of case notes and learning from relatives in a way that hasn't been possible before, I think is really exciting and important. And what we found from relatives is that they really welcome the opportunity to feedback to independent practitioners about the care. I have to say that most of the feedback from the community is positive, whereas in hospitals we tend to get a bit more of a mixed bag of feedback. But it's really important to identify potential learning as well as excellent care that we can feedback to teams. And the opportunity for the community is to feedback to all teams. So any provider may be the source for potential learning or positive feedback. And then what we're also looking at as a sector-wide group is how we explore themes from learning on a kind of more sector-wide level. I think the last slide that we haven't looked at yet is just about when all this is going to become statute. And what we hear from the DHSE, although it's still somewhat uncertain, is that it's going to be from April. And it will then become the law that every death that isn't referred directly to the coroner has to have a medical examiner scrutiny. But I think we're in a great place for that to be in place. You know, all our GPs have had training and they've had an opportunity to experience the process. That's all I wanted to add, but we also wondered if you had questions. Peter may have more that he wants to add.
Thank you, Sarah. No, I think the only thing I would add is that we were more than aware from day one of the time element that this presents, and it's an extra step in the process, which inevitably means, yes, it may take a little bit longer than it used to, but we've factored that in from day one, and particularly as Vijay mentioned with deaths from faith groups. The way that we've set up the system for the referrals to come into the medical examiners, I think is about as slick as we could get it, but it also highlights straight away whether there is an urgency with this particular death, which enables the medical examiner teams to prioritize those ones. So as it said on the first slide, I think the aim is for this whole process to take no longer than 24 hours. And I think we've been doing this now in acute trust for a good 4 years, and we've been doing this. And I think the extra year has probably given us more of an opportunity to refine it and get GP steadily on board with it. And like as Sarah said, I think the feedback in the general has been good.
Great, thank you, Sarah and Peter and DJ. Councillor Mason had a question, comment.
Yeah, just a few questions and comments. I think so. Firstly, I think the feedback on or the assurances that you're giving on the 24-hour notices, I think, are important. I think it's worth reflecting, as I'm sure we all know, the 24-hour target is one of those ones in which it's actually not necessarily 24 hours, but sort of the speed at which from death to committal that can take place. So, you know, in an ideal world for some of our sort of faith communities, that would be sort of ASAP, and it wouldn't be defined as 24 hours, but 24 hours is also an important time point. So I think that's worth bearing in mind, that yes, the process should probably no longer last than 24 hours, but in certain circumstances, the experience, of course, for many of those faith communities is that they are able to achieve committal before the 24 hours at this point. So this would naturally be, or appear to be, unless it can be done efficiently, an elongation of that process. And so assurance around that is important. But I suppose I've got two questions that relate to capacity. So, you know, medical examiner workforce, this feels to be like an additional degree of activity that medical examiners will need to do at a volume that is not necessarily that which they are doing at the moment. And whilst I appreciate that might be manageable in the context of acute trusts, I think, you know, we're all having conversations, are we not, about the sort of the prevention of people having to be in acute settings. And if we're anticipating over a longer period of time that medical examiners are going to have to be sort of being involved in the review of cases within community settings and not acute trust, then presumably that's a significant increase in the overall workload of a medical examiner. So what are the workforce issues here?
Shall I take that one, or BJ, do you want to take that one?
Yeah, you take that, Sarah.
So we are funded by the DHSC directly, and the resource was worked out on an equation which I wouldn't say is entirely adequate, but we have been coping with. And then there was an uplift in resource to take account of the additional community work, which was based on the then community deaths. And we received that some time ago because of the expectation that this was going to be rolled out to community and made statute in April 23. So we've already had that resource, and we have that within our teams. And that's the resource that we're going to use to roll out the service to the community. So it is a separate resource that's additional. Is it adequate? Probably not entirely to do a really, really good job, but we absolutely know that we need to prioritise faith deaths. So faith deaths, paediatric deaths, organ donations, we would always prioritise those deaths for scrutiny. I don't think there's going to be more money available. I'd be interested to hear what Peter thinks, but we're working within the envelope we've been given, and we've definitely been given additional resource to roll this out to the community.
Sarah, yeah, no, I'm not aware of any additional funding, but yes, we were sort of funded on, I don't know what the ratio was, but yeah, based on acute deaths, community deaths, and we're already funded to that. So we're kind of appointing medical examiners into post in advance of April 2024. And we also have medical examiner officers that are part of the team. So they are they're not qualified clinicians, but they are full-time employees who work in the office 37.5 hours a week, and are kind of the glue that holds it all together, really, to make sure that, you know, the medical examiners are reviewing the ones that are the priority, and we're funded for those. So I think it's different depending on which medical examiner office site it is. So I know from my side, we have 5, soon to be 5.5 medical examiner officers who are full-time, who are always in the office. And so I think, yeah, the proof will be in the pudding when it comes to April, and every death is coming through here, other than those that go direct to the coroner. But from our perspective, we're around about 60% of deaths in Ealing are coming through the medical examiner office, and the resource that we have at the moment is managing quite well with that.
Thanks. Simon, did you want to come in on that?
I was going to add, but I think, to be fair, Peter's covered it, in the sense we're not relying on one individual. We've got a couple of individuals who perform the role, and have got PAs dedicated time to undertake the role, and one of them is the deputy medical director of the trust. So he's not necessarily frontline clinical staff all of the time. So it's a part of it. It's a managerial role and capacity as well. But there are others who are able to support him in that.
Thanks, Simon. I think on the wider learnings, it would be really helpful to include probably the council on that, because if there is learnings coming from deaths in registered care settings and so on, I think that would be really helpful for Kerry and the team to see, so that we can keep an eye on what's happening in that sector, rather than it being siloized in that way. I can see some nods, so people are agreeing. Neha?
Yeah, so I think that's a really, really good point. And right at the beginning of the program, as we started to develop this model, we were thinking about all the different parts of the system that we need to make sure that we are talking to. So that includes funeral homes, that includes registrars' offices, that includes the learning from care home deaths. It could be feedback for pharmacists, it could be feedback from any part of the system. And we've been trying to think of an efficient way that doesn't add additional inefficiencies to the medical examiners team, about capturing that learning, or capturing the themes at least, so that we can systematically then think through, okay, is there something of concern coming here? And then how we link that in with our quality governance of the ICB in particular. But I'm really keen, as part of this conversation, I'm really glad that's outed that, is, you know, say, for example, if there's learning from a care home, how we make sure that that does get fed in.
Yeah, just want to find out that there's also, from a national perspective, there is development underway in terms of digitalizing the certification as well. So that will, in fact, help support that sort of that rapid turnaround, if we're able to use digitalization in terms of certification and that transmission, not only the work between the doctor and the medical examiner, but also in terms of that certification to the registrar's office as well. So that will also support that quick turnaround process.
Great, thank you. I can't see any other hands up. I think Chris's is a legacy hand from earlier. But I will give him a second to.
Yes, it is. No, not a new.
Excellent. So if not, Sarah and Peter, thank you very much for joining virtually, and Vijay for presenting as well. Thank you very much for the update, and best of luck with the 1st of April, if that is indeed the date in which pieces of paper are signed by Secretaries of State to go live. But thank you very much.
Thanks very much.
Thanks very much.
So I think we come to Julie and Madhu for the SEND strategy and self-evaluation.
Hi, everybody. Hi, so my name is Madhu Bachu. I'm the Acting Assistant Director for SEND and Inclusion. And we have Julie with us as well.
Julie Lewis, I'm the Director for Learning Standards and School Partnerships.
So thank you for inviting us today. So I'll just wait for the slides to
There we go. Thank you. Thanks, Sam. So the purpose for today really is to ensure that you're all cited and have a shared understanding of the quality and impact of the local areas arrangements for our children and young people with SEND, so we can inform our partnership commitments, prioritisation and joined up working. See if it works. Oh no, not working. Thank you very much. So what I thought I'd do just to start off with is just to give you a picture of the current landscape in terms of educational health and care plans, because it's been a big increase in demand, and that's going to affect the work that we do. So Ealing had the 6th highest number of plans in London in January 2023, when nationally we collect the data. This has increased further in year to 3,658 children with educational healthcare plans at the 6th of October, and it's continuing to increase. We've had a 10.5% increase in the size of the total EHCP cohort, and year to date, and that's of October, that we had 626 initial requests. That's the 8th highest in London. And if you sort of think about this time last year, we had 447, and we've already got 503. So you can see the difference year on year. And year to date, we've issued, let's say, 503 plans. So that's giving us, a real pressure within the system. And in terms of the needs that we're seeing, there has been a change in the complexity of needs. So we've got an increase of children with ASD, social communication needs, but with an additional need on top of that. So it could be a physical need or sensory need. And then an increase of children with severe learning difficulties, with autism or behaviours that challenge. So that's the change in need that we're seeing across the system. So really, for us to think about what can we do as a partnership to address the increase in demand. I need to thank the public health team and Vaish for helping us to work through a SEND specific JSNA. So that's the work that we're undertaking at the moment. I think that's going to really help us to really understand and go underneath our cohort of children and what's sort of coming through as well, so we can better plan and prepare as a local partnership. So obviously it's what we provide in our schools for early intervention, our early year settings, our health services as well. So thank you to them for helping us with that. And we're hoping maybe February time we'll have one to share, but I know it's a big piece of work. So then we'll use the data from the JSNA, SEND specific JSNA, to refine our strategy action plans. So just want to spend just a couple of moments just sort of reminding ourselves of the local authority SEND strategy. It was launched in April. You will have obviously all seen it. But just wanted to flag up some of the key priorities and what that means in relation to the demand that we're seeing. So with priority 1, this is about improving guidance, but early identification of need and support for children, young people and their families, so that schools and settings are supported to welcome every child. So we've seen 100% increase of children that have been excluded from this time last year. It's 11 last summer, we're at 22. There's an increase of children that are on reduced timetables, so spending less time in school. There's an increase of children with EBSA, emotionally based school avoidance. So, for us to meet that aim, we need to really be thinking about how we're supporting those groups of children, and the work we're doing with therapeutic thinking, again, which public health has supported us with. I think we will start to see the impact over time. There's a lot of work we need to be doing at the earlier stages. Vijay and I had a really good conversation at the Children and Young People's workshop around school readiness, and that's where this would all sort of fit in. Priority 2 is really thinking about how we prepare our children and young people with additional needs for adulthood and for the most independent life that they can have. So really thinking again, how can we engage more effectively as a partnership to ensure that our children have a sort of seamless transition really into adulthood? What is it that we can do there? Priority 3, really thinking about co-production, how we work together with our families and our young people to ensure that their plans actually, capture what it is that they desire, what they wish to achieve in their lives. And again, with this priority, and we were talking to Neha today just about this, about our multi-agency quality assurance that fits into this priority there. And priority 4 is really thinking about sufficiency. Do we have enough specialist places within the local authority? It's a big piece of work that's happening at the moment. Again, we need to work really closely with our health partners to ensure if we can create the spaces, those children still need nursing care and other care needs that need to be met. So it's really important that we bring those conversations together, and then thinking about the wider local offer. So I just wanted to just highlight, I guess, where the SEND strategy and our CEF really fits in with the wellbeing strategy, the health and wellbeing strategy. And actually, we do have an action point within the action plan, which is around supporting the implementation of SEND strategy and action plan, including a greater focus on early intervention and working towards becoming an autism-friendly borough. So there is that direct link between the work that we're doing. So it's to keep this alive within this space is great for us. So our self-evaluation, you all would have read it, so we're not going to do it in too much detail, but just wanted to flag up some key points, just to share the process that we went through to get to produce the self-evaluation. We held a series of workshops, we had about 3 or 4 actually, over a period of time with a range of partners, a range of service providers, young people and our families, and we gathered all of that information and put that together into our self-evaluation summary. We shared it with our Link DFE regional advisor, who liked it and was impressed with our level of honesty actually, and our true understanding of our partnership and how well we know ourselves, and also the actions that we've put in place in order to move forward. She felt that they were right. I'm just going to flag up very quickly 2 things. If any of you have time tomorrow, at Project Ealing, we have a poster exhibition on. We put a competition out to our children and young people to talk to us about what Include Me meant to them, to help us when we were doing the CEF, and we ended up with about 25 different entries that we couldn't choose between. So we've just put a little exhibition up in Project Ealing. So if any of you walking past tomorrow, please pop in. I promised that I would share that. Okay. So with the CEF, there's 11 criteria, and it's broken up into 2 sections. This is the Ofsted self-evaluation framework. And the first section is around children and young people's lived experiences. So when Ofsted inspectors come in now, but what's changed, which I think is great, is that they'll be spending more time talking to children, talking to young people and talking to families. It's okay, we can say we're doing these things, but actually what's the impact on the ground? What are they experiencing? And then the second section, which is key for us, is around leadership, partnership working, and our aspirations for our children and young people with additional needs. So you can see there that we've graded 8 of those areas as inconsistent. So we feel there's inconsistent experiences and outcomes for children and young people with SEND, and that there is a need for stronger partnership to make improvements. And as I say, these judgments come from a range of stakeholders. We've had, I'd say, well over 80, 90 people involved in putting this together. So it's really important that we're here today to share this. So thank you for that. Just wanted to highlight some of the key priority areas that came out of the CEF. So we've got strengthening the voice of children and young people. Again, I think we need to really think about strengthening the voice, but also having a consistent and systematic approach to how we gather children and young people's voices. And then what do we do with that information once we have it? And actually that links in with our families as well. And again, we were talking today with Neha and the team about, I think we all do gather feedback, but how are we bringing that all together, and then thinking about the key themes, and then thinking about what our next steps are there. So it's a piece of work that we want to be doing. Thinking about a governance structure, Julie's going to talk about that in a moment.
We really want to develop a send data dashboard where all of us can put the key information and data together that's the evidence behind our self-evaluation, and also be really transparent with our stakeholders about our data, you know, what our KPIs, what is it we're aiming to achieve, but also what's the baseline and what's it look like now. So that's a piece of work that we really need to, you know, get going really. Preparing for adulthood, I have talked about that. So really thinking, how do we work together to strengthen transitions and our pathways and opportunities for our children and young people, and really starting at the earlier sort of stages, not just thinking about when they're, you know, 16, what do we do now, but really thinking about the earliest of stages really, and planning for a successful and independent adulthood. In SEMH review, again, I've mentioned there about therapeutic thinking about our alternative provision and quality assurance, you know, ensuring that we're satisfied where our young people are being educated, improving our communication and refreshing our local offer. So we're in the process of refreshing our local offer website to make it more accessible. But for us, the local offer is not just a website. It's, I think, as many of you have mentioned before, how are we getting out into our community, how are we sharing what the offer is, and so that everybody can access the services that we have, and we're getting best value for money, because we do have a lot of good services in Ealing, but are they being used, you know, as much as we want them to be? So that's something that we, you know, we do need some support with, and making sure that all our frontline workers actually understand the local offer. So when they're working with families and schools, they're promoting what we have in Ealing, you know, across all our stakeholders. Thinking about our commissioning strategy, there's a lot of work that's been going on there, particularly with our short break work with the commissioning team. So redeveloping that strategy is part of our priority 4 and sharing that across our partners. I've talked about quality assurance a moment ago. So they're the key things there that you want to talk about. The one thing that I think we're all struggling with is recruitment and retention. So to say that, you know, it's a similar thing here, but also in terms of our school workforce and our nursery and private and voluntary independent nursery workforce, there's a lot of struggles in that space. And for our children, young people to get the education that they need and support that they need, we really need to be thinking about how we're recruiting to our workforce, but also retaining the workforce that we have. And I think that's about all of us working together to offer training, to offer a wider outreach offer, so that people can actually be upskilled. And that's where we want to work with our speech and language therapists, our OTs, etc., and our health colleagues to think about how we can build capacity within the school workforce in order to meet our aims. Just wanted to flag up, there's a new Ofsted framework, and there's been about 15 or 16 local authorities that have been through the process now. 5 of them have had a good outcome. The rest are sort of amber and red, if you like. But I just wanted to flag up the 5 key areas that have attracted the most recommendations out of the Ofsted inspection. So it's for us to be mindful of, really, and to think about how we're going to work on these areas together. So access to health services, identification and assessments. This is about review of EHCPs, so annual review cycle, including our timeliness. So just to share here that in March, we were at 36% with timeliness, meeting our timeliness KPI. We're currently at 82%. And I just publicly want to say thank you to the team for making that happen, because there's a lot of people involved in that. And it's been through, you know, sheer hard work and dedication. So just wanted to raise that in this space. The quality of content, so that's about the quality of the advice put into an EHCP plan. And again, we're working with health colleagues around training around outcomes and how to write a really smart, targeted outcome for our children. Thinking about the experience of families and how we ensure that the voice of children and families is within the EHCP process. So co-produced right from the beginning stages. So third area that has come up in inspections is joint commissioning. And this is related to the quality and use of information to support commissioning and evaluation of the effectiveness and impact of commissioned services. So I think we all know there's a lot of work going on in that space at the moment. We're working towards a new contract with our therapy commission. So, you know, there's lots of work in that space, but making sure that we're all on the same page and we all understand the work that's going on so we can articulate that. Co-production, and I've talked about that, and obviously preparing for adulthood. I'm going to stop now and pass over to Julie.
Thank you, Madhu. I think Madhu set out all of the partnership priorities really clearly. And I think one of the things we were doing as we're looking ahead to the CQC and Ofsted inspection is that it's an inspection of a local area rather than a service. So it really is, you know, how all partners and collectively do the very best they can for children and young people with additional needs. And one of the things we wanted to really refresh and sharpen were our governance arrangements, and make sure that all parts of the system understood those governance arrangements and the purpose of each of the structures that we've got. So we're still rebuilding our governance structures, and we've got some meetings coming up this week. But the board at the centre of scrutiny of our strategy for children with additional needs and special educational needs is the Send and Inclusion Strategic Partnership Board, which is the grey rectangle sort of right in the centre there. And we had to sharpen the terms of reference and the membership to create a much more active governance model. So now every single member of that board is linked to one of the 4 priority areas, and they have an active role in scrutinising those areas and in talking to children and young people and families about their experience. So we're really keen to bring the whole kind of governance structure to life, and also for it to have coherence then as one of the children and young people's board kind of subgroups alongside mental health, which we've talked about today, and early help for children. And then obviously we're really keen to know how this governance structure and this board can also collectively contribute to this endeavour, because all the bits of the system have to join up to achieve these 4 key priorities that we've set out here. So that's it, really. I think from us, we're very happy to answer any questions.
Great, thank you very much. And again, another kind of comprehensive slide deck that belies the comprehensiveness of the background material behind it that was in the pack. So thank you very much for all the hard work that's gone into that. Any questions, comments from members? Simon?
Earlier in the slide pack, you mentioned about the learning from others, and the first one you talked about was around access to health services. I'm not clear from priority areas or what's in here whether there is a particular issue in Ealing around access to health services, and if so, what is it? Because I couldn't see it. I haven't forensically read this, but for my quick scan of it, I wasn't picking up what those gaps might be if there is something that we need to know about.
So that's a really good question. So I think I mentioned about the sharing of data and the fact that's something that we need to be doing doing more actually between ourselves and health, and really understanding where those gaps are. We access to that's come from all the local authorities, and the key theme that's sort of come out. I think for us, we do know currently in our schools, our children aren't getting the
not all our children are getting the therapy needs met in terms of what's in their education and healthcare plan. So in their plan, it states whether they need, 10 hours or whatever it might be. And there are a number of children that aren't receiving that therapy due to shortage of staff and staff turnover. And that's something that we're working with our health colleagues on to really understand that data, because it's changing all the time. So that's one of our key areas, is definitely therapies for our children with plans is the first place that you want to be thinking about. Then obviously we've got children having access to CDT assessments, also having access to educational psychology, because at the moment they really sort of their time is being spent on statutory assessments and not that wider work that we need to happen in order to support the children that potentially aren't on plans. So this is not just about children with education and healthcare plans, it's about children on SEND support and undiagnosed need. So it's the whole sort of range really. So it's for us, it's definitely therapies, children not getting all their needs met that are named in their plan. That's our key priority, number one, that we need to be thinking about. And then it's about the universal approach that we can offer. And we're working with our colleagues around that and looking at the contract, the therapy contract at the moment.
Neha, do you want to pick up on that?
Yeah, so there's a couple of things in that. So I think having that data will tell us where the gaps are. So then we can develop the action plans to try and address those gaps. We have quite a bit of information and anecdotal information, but it does change. And having that strong data is going to give us what we need to really then target the action plans on. And I think for the inspection, if we understand where that is, what our action plan is, what that joint up position is, then and that's the best thing for the children as well, because then we're working to a known gap. But at the moment, it's not strong enough, I would say.
Thanks, VJ.
Yeah, this is a point, not a question. And first of all, it was really pleasing to hear about the level of engagement that you went through particularly in relation to the self-evaluation, because we know that in terms of human nature, when you are self-evaluating, normally you play safe and you score yourself somewhere in the middle rather than the two extremes. And so that's really important, that level of engagement in terms of how you self-evaluate yourself, because it can often be meaningless in terms of others looking at it from a different lens outside your own working environment.
Thank you. Councillor Mason.
I mean, I suppose I would hope, Vijay, that's what we would all do in critical practice when engaging in self-evaluation. I think perhaps, without wanting to necessarily be too critical of another part of the partnership arrangements in the borough, maybe when H&WBB sort of came to inspect youth justice, perhaps we weren't quite as clear-sighted on that as we thought we would be, given that we still got requiring improvement. Perhaps when we thought we were in a different place, and partly that's one of the contributions I want to make to this conversation, which is one of the learnings that we took away from the H&WBB inspection is in many ways is a different picture, but I probably shares the same theme from that which we see in this self-evaluation, which is that we broadly were all on the same page. We broadly assented to and accepted a theory of change in a trauma-informed approach to young people who are engaged in crime. But the consequential impact of the way that we behaved didn't quite match that which we had a common understanding of. So in layman's terms, you might say that we all turned up at the meetings and we all agreed with each other that this is what we should do, but that didn't necessarily flow in terms of our values and behaviours across all of our organisations. And the Met have got enough on their plate that they need to sort of buck their ideas up, and certainly they, less said on that, the better. I suppose, therefore, my reflective question to everybody in this space, and I'd be interested in observations from those who are around the SEND table, do we think that that is right? Do we have a refreshed partnership? Do we have both the sort of the common understanding of the purpose, but then also is that held locally too? Because, you know, I reflect a lot, not just in the context of LSP meetings, which have been thoroughly boring for the last couple of years until probably our last one, which I thought was very good actually, where we tried to experiment with different models of governance that sort of put the discussion and the function of the output first, rather than necessarily the churning through of governance paperwork. You know, what do we actually need to change in that space to bring more energy and passion and commitment into those governance arrangements? Because I look at Amber and I look at Amber in the leadership space, and I do worry that if we're not careful and we're not a bit bolder about what our response to some of that evaluation might be, is that we could potentially find ourselves in a situation which we've been in recent months that wasn't particularly pleasant.
Thanks, Councillor Mason. I don't know if any partners want to reflect back at this point, or take it away and reflect as we move forward with progressing some of the recommendations. Simon.
So I think that there's a commitment and willingness, but I think it leads to my last question, really. It being really clear what we as partners can do to help is really helpful. So sharing that data and finding a way of doing that would be really helpful. I'm sure there will be some aspects for acute, but it's probably primarily community health services is the primary issue, but I haven't got the sense that the community are necessarily terribly cited on. I may be a bit unfair because I don't sit on those groups, but we just need to be really clear what we want from each other to make a difference. But I'm sure there is that commitment. It does feel like a fairly strong partnership in Ealing, and I do sit in Brent and Harrow as well. So my sense is the commitment is there. We just need to be clear what we want from each other and moving that forward.
Thanks, Simon. Neha.
Yeah, I would agree with that. But I also think over the last however many months or a year or so, we have really tried to be honest with each other, get around the table, have the conversations about where the issues are on different themes, lots of different themes, and get the right people across the partnership together around the table to thrash things out where, you know, we're not all necessarily on the same page. And I think we're starting to come out much stronger as a result. So that honesty is really important, which and then having really strong, clear plans and who is taking on what bit. The danger, I suppose, is there's so much to do, is who has the capacity, how much capacity do we have, and do we need to chunk up and prioritize what we need to do, but then have visibility on what else we need to do. And that's in the context of the ICB, which I'm sure you all know has to make a significant saving in its running costs. So from an ICB perspective, the workforce might reduce to be at that table, but that's where we need the rest of the partnership and all the providers to sort of step up and be that active voice in that partnership place. But I think the commitment's definitely there.
I can't speak for other partners, but I don't know we're going to have a 30% increase in our representation and ability to contribute, knowing the state of local government finance. But noted, and we know that's a challenge coming down the line that will affect everyone. Robert.
I think it's a really exciting opportunity, but the level of the challenge is huge. I think if you just look at the early part of the slide deck, it does highlight the extent of the challenge. What we do know is in Ealing, we've not been part of the government's Delivering Better Value programme. And essentially that is for the 30 plus local authorities and partners where there are significant concerns in those first three phases that they are not working as a partnership to appropriately meet the needs of children with special educational needs and special needs. So we're in a different place here, but I think what we have found through the self-evaluation process is that there were areas certainly where we just need to be much more robust as a partnership, particularly, as colleagues have mentioned, with our governance. I think the position of the Health and Wellbeing Board is extremely important in terms of that top tier of governance, and just to reassure everyone, I think myself, my colleagues here from across the partnership, we will come here and be really clear if we think that we're not making the type of progress that we need to make at the pace we need to make that progress. I'm really pleased that through our contacts with other local authority areas, we've been doing our due diligence and finding out what makes the outstanding judgments outstanding, and also I think we're finding out what's been some of the problems and pitfalls that have been experienced by the authorities and the areas that have been struggling and seen poor outcomes. So I think we have reinvigorated the governance space. I think, as Neha rightly highlights, there's some very good object lessons, particularly in the mental health space, where the partnership has worked really well. I know it was one of the first meetings that I attended when I joined the local authority, and we've seen some success in that area. And albeit it's probably a smaller area in terms of some of the challenge, but I think it's built a great deal of confidence amongst the partnership, and also an appetite to maybe step into this area with real gusto. But yes, we do need to make sure that we continue to have those honest, direct, and supportive conversations with each other in that governance space.
Thanks. And then I think Anna, final contribution before we have to move on.
Yeah, just wanted to echo some of that. I think especially with Neha and Robert alluding to, I think there's been so much work seeing children's as a system and the complexities of that, and even just, there's time being spent on that, and I think it's been really valuable, and I think it is having those honest conversations. It feels like a massive group where we can have those conversations, and we do. So I think where we are coming to some of the statutory areas of the self-assessments, it feels like we're having real conversations there. There's an awful long way to go. Even sat in that room, if you say, what's this service, between us, it's hard, let alone for people out there. And that's not just children's, that's everywhere. But I think there's a real commitment there and a real drive to kind of push that forward. And I think Robert coming in to chair that group with NHS partners, I think is really key to that.
Great, thank you. So I think the challenge will be that those conversations are followed with action and progress, which I'm sure you'll update us on as we move through, and thank you very much for all the work in preparing this. So thank you very much. We move on to Simon, I think, NHS North West London update.
Yeah. Apologies. So there's a slide pack produced. I'll just talk through the first one really in terms of the overall update, and happy to take any questions. But clearly the acute trust continues to be significantly challenged in terms of the number of acute presentations that we're seeing. With our emergency activities up 18% on 2022. Our performance on type 1, type 3 is 73.7% against a target of over 80. Day in, day out, we are having to offload patients into corridors and cohort them at both Northwick Park and Ealing. And there are times where we're having to sort of +1 patients in the wards in terms of to free up space in the A&E department to assess and treat the most acutely unwell. So that's challenging on both our sites, not to the same degree at Ealing, but we're definitely doing it at Ealing on times as well. And therefore that puts pressure on the back end as well, in the sense the need to discharge patients in a very timely way. So it's really important that we can do that as efficient, as effectively as we can. And we clearly work with our partners in terms of social services and community partners in terms of West London Health in terms of doing that on a day in, day out basis. So the overall message is pressure on the emergency pathway is big. We have got, we've already opened some of our winter bed capacity on the Ealing site as a consequence, and we'll be opening another 10 beds later this month. Later in December. It was due January, but we're planning to bring those forward and open those in December now. On the elective side, and you see some of this, I think, in the Health Watch report earlier on, we have been impacted by the number of strikes that we had across the year. Fortunately, we haven't had any in November, but that has impacted the organisation. The statistics are in the slides in terms of the number of operations we've cancelled and procedures. We've clearly continue to focus on rebooking those patients who are cancelled, but inevitably with the series of strikes we've had, there are some patients who got cancelled on more than one occasion. That is frustrating for patients, obviously, but it also is then complex in terms of the rebooking of patients. So again, I think that feeds in the Health Watch report in terms of some of the frustration around cancellations and access, and how busy some of those clinics they're now when we have put them on, and the waiting associated with that. But we do prioritize the cancers, we do prioritize the more urgent cases, and we are prioritizing the long cases. And again, you can see from the slides there in the pack, the long waiters, they have gone up, but we're monitoring those on a week by week basis and making sure that those longest waiters are being treated and prioritized by clinical teams in doing that. Anything else? So happy to take questions on most of that. On the positive side, the positive is, as challenging as it is, our staff I think are responding to the challenge and making sure that we do treat patients well and with compassion where we can. And then the last thing on the slide pack is around the community diagnostic centre that will begin. There's a phasing of the different elements that will start to go live from December of this year before it goes up to full capacity by March of next year. Happy to take any questions.
Okay, thank you. Any questions for Simon? Kerry.
Thank you, Simon. In terms of the work that's been done in terms of capacity building within the community over the winter, I think the work around the additional capacity to support care homes with challenged behaviours is a really important piece of work that's been done as a whole system, and just wanted to highlight that. This will support more complex need patients coming out of hospital, which are often one of our longest delays in terms of the discharge pathway, and support them into care home placements. And I think it's a recognition of a significant amount of work that's been done within the partnership around that piece. On top of that, the council's working to create an additional 15 complex residential dementia beds, which we expect to be online towards the end of this financial year, which will support the flow of patients also. So that's really positive. I did want to ask a question about 7-day working and discharge pathways over the weekend, something Neha and I have been discussing about, and it's almost a bit of a sacred piece of the NHS strategic direction that 7-day discharges should be part of the way forward. We're not finding that we're getting the traction 7 days a week over the weekends. We're putting additional capacity in. Just wanted to see whether you had any thoughts whether those resources could be better used on a Thursday and a Friday than a Saturday and a Sunday.
So that's probably worth a conversation outside of here. I think the frustration I think we've all experienced from time to time, unless the whole system is working 7 days a week, it's very difficult for only certain parts of it to work 7 days a week and have the same impact. So a good example is the number of the care homes are private providers. They won't necessarily accept discharges over the weekend, and certainly not on Sundays. And for some, they'll only accept them when the care home manager is there. So we can do all the work that we like around the package of care, but if that's the right place for the patient, it's the right place for the patient. So instead of going out on a Saturday morning, they stay in the hospital to the Sunday. But there certainly are things that we can do, and there is more flexibility on a Saturday rather than Sunday. And whilst it's not NHS policy, from my perspective, from the acute trust who sort of leads and support our discharges, I'd rather we got the 6-day service working extremely well, rather than try and kid ourselves that we can get a 7-day service working. And we've all got resources in place that isn't perhaps being used as effectively as it can because the whole system isn't available to respond in the same way. But be very happy to have that conversation outside of here.
That's really helpful, thank you, and it's something we can certainly pick up and look at in the short term.
Great, thank you. Anything else for Simon? No, thank you very much, Simon. And then it brings us on, I think, to Health and Wellbeing Board work programme. Anna, anything to highlight for the next meeting or two?
Thanks, Chair. So apologies in advance, I shared with poor Sam my slightly messy working version of this rather than a neat one, but you'll see from January we've got 2, hopefully 3 substantive items. So we're bringing a kind of half-year update on actions against the health and wellbeing strategy, how we're doing with those. So that will include both a kind of line-by-line action plan, just bearing in mind that some of those are year 1 specifically, some are kind of year 1, 2, 3. So some of them are starting in early days and some are further advanced, and also a selection of what's coming together as really nice case studies of where the health and wellbeing strategy has really been helped drive work. Really nice with the SEND strategy to see it. Thank you, Maddie, in there. There's lots of things across council and the wider partnership in there. So we'll be bringing that through and then move to a kind of annual review in the summer. Adult services bringing the carers strategy. I think that's my understanding. Obviously, double check that. That's the plan. And then we're waiting for formal announcement and news around the research collaboration news. So if that gets agreed formally, then we'll bring some updates here and some plans for taking that forward. You'll see in my slightly messy notes underneath, there's lots of work and actions within the strategy action plan itself about the Health and Wellbeing Board. So there will be a piece of work over the winter about reviewing how the board works, membership, how it engages with communities, etc. So I think there will come a number of kind of longer term planning items in there that we can feed in. Thank you.
Great, thank you very much. Helpful overview of what's to come. The only other business then is that we did have a question from Roy about, I think, digital exclusion. I think, Kerry, that you can pick that up. Roy, if you can, there you go.
Hello, yeah. Yeah, just one question. Back to digital exclusion again. I read an article in the New Statesman that estimated there's over 5 million adults in the UK who cannot send an email, access websites, or book medical appointments online because of lack of IT skills or no access to a computer, etc. Got me thinking, really, what's the figure in Ealing? And also, you know, how many thousand does that mean in Ealing? And is digital exclusion getting worse because of the rising cost of living, the rising costs of broadband and digital devices? And really wanted to call on Ealing and Ealing Council and the whole of the council, not just social care, but also the health authorities, to develop or expand plans to include local businesses and local voluntary groups, especially those disability groups, in a concerted effort to provide IT training and access to laptops and mobile phones at discounted rates, broadband at discounted rates perhaps. I think also I wanted to add really that as well as trying to expand and get more people accessing online, we do need to keep, while the numbers are high, we do need to keep other channels of communication open so that as people can still seek help or find get advice and information. Okay, thank you.
Great, thank you. Kerry, do you want to pick up from the adults' perspective? And then I think Councillor Mason was going to come in on a wider point.
Thank you, Chair, and thank you for the question, Roy. I will go away and come back with some information after discussing with colleagues what we think the digital exclusion numbers and proportions are for Ealing, and I'll hopefully have that answer for you in the next couple of weeks. Absolutely, the digital exclusion does impact on communities in Ealing, and it varies across communities. We know that people with mental health needs are particularly digitally excluded, and we know that other communities in the borough are also impacted by cost of living crisis and their ability to access digital solutions. Within adult social care, we recognise this, and we've developed a programme of newsletters updating and providing support to people which are going to go out on a quarterly basis. We've been working with the voluntary sector to help them maintain their non-digital channels of communication with the communities and customers that they serve. We've also worked in the past, certainly through COVID, about providing access to IT equipment for vulnerable people in the borough, and I'll get a further update on that with colleagues as well in terms of our current position in that space. But thank you, Roy, very valid question.
And as your colleague Kerry, I'm very happy to. Yeah. So at the beginning of the year, we launched the Reclaim IT project, in which the council basically made a big commitment to donate over 1,000 of its sort of surplus laptops, and it's a program that's run sort of up via H&WBB, in which you don't just get a laptop for those who, if you like, the most digitally excluded in the borough, who sort of go either through a referral or get picked up through many of the various different sort of interfaces that the council has, and also through voluntary organisations. But there's also sort of a 90-minute training session that goes with each and every one of those laptops, and check-in points at the 30, 60 and 90 day marks for the project, to ensure that people sort of have got the hang of it. And obviously, you know, the point taken that we're of course always going to need to maintain some elements of alternative sort of channels for people to access. But you know, the project really was to try and really put our sort of support where it needs to be in the context of those sort of most digitally excluded, and certainly would encourage everybody to access that scheme. It's still going and likely to continue for some time.
Great, thank you. Chris.
Thanks. I just thought I would add, and I'm happy to talk to you outside the meeting, Roy, about this, that West London Trust won a bid successfully from the Captain Tom Fund, if you remember, through the NHS Charities Together programme during COVID, to put together a programme called Powering Recovery in partnership with Ealing and Hounslow CBS, with Mind in Ealing, and with Dementia Concern Ealing. And we've been running both, well, it was a 3-programme approach, providing device and access to data, providing skills training and group work, and linking people with online services, including for care and health, which has got some really positive outcomes and has recently been shortlisted for a national award. So I'm very happy to share with you the outputs of that programme, which we're currently exploring how to sustain.
Thanks, Chris. Roy, if you get in touch with Chris offline.
Thanks. That's very helpful. I did want to say that obviously training, I know, is on offer, but it might need much more support and even more outreach, perhaps to train people in their own homes. People who are housebound, or people who are unable to leave their house for whatever reason.
That's exactly what we were doing, Roy, and it linked with our volunteering programme, because there are a lot of very digitally literate volunteers who are willing to work with individuals outreaching to where they are. I'll fill you in when I next see you.
Okay.
Great, thanks, Chris.
Thank you.
Peter and Kerry, for that overview of what's happening. Carleen.
Just picking up on the last comment, I've also met with one of Kerry's colleagues about the digital exclusion project. And we are putting together a list of all of the groups and communities in the borough that do offer out digital technology as well. And Age UK are offering digital training for residents in the borough. And GPs in the borough have also been showing residents how to use online software for booking appointments.
Brilliant. Thank you very much. Thank you all very much for a very long evening, some very comprehensive items, but hopefully we'll have some lighter meetings in the future. Just the implementation of the health and wellbeing strategy, nothing too much, right? I won't see you until after Christmas in this format, but I'm sure I'll see some of you before then in others. But if not, have a lovely break, and I shall see you on the 10th of January for the next meeting of the Health and Wellbeing Board.
Thank you, Chair.